So today let us discuss about jugular venous pulse and JVP examination. Jugular venous pulse is nothing else but the topmost oscillating vertebral column of the blood, which is observed visible at the right internal jugular vein, which indirectly reflects the right atrial pressure, and the jugular venous pressure is nothing else but the vertical height of the oscillating column of the blood. Why internal jugular vein is preferred? Because it has a direct course to the right atrium, anatomically closer to the right atrium. It don't have valve like our EJV or the external jugular vein. And remember, the EJV passes through various tissue planes, and the vasoconstriction secondary to hypotension can make EJV small and barely visible. But all these things are not seen in IJV. Why right IJV is preferred over the left? Because right IJV has almost a straight line into the superior vena cava, unlike the left, which you can see in this picture, which has a kinking course. So this is how you have to measure the internal jugular vein pulsations. You have to use two scales, okay, one and this one, two. One scale is placed perpendicular at the level of sternal angle, perpendicular to the level of or perpendicular to the sternal angle, and another scale has to be placed horizontal to the first line such that the topmost border of the scale corresponds to the highest blood column, highest oscillating blood column, and at this point, the topmost border intersecting the first scale, this point gives the vertical height of jugular venous pulsations. So two scales, one perpendicular to the sternal angle, second scale should be placed horizontal to the first scale such that the upper border of the first scale should be corresponding to the topmost oscillating pulsations that you are seeing, and the intersecting points gives the jugular venous pulsation. So how jugular venous pulse is different from the carotid pulse? It is more lateral, it decreases with inspiration, increases in supine position, increased with abdominal pressure, it has two peaks, it is obliterated with pressure. Remember, venous pulse is better visible, better view from the foot end of the bed, whereas carotid pulse is having single peak, no change with the posture, no change with inspiration, cannot be obliterated, it is better palpatable. So, as I told you, the patient should be reclining with the head elevated 45 degree, neck should not be sharply flexed, okay? And as I told you, using two scales method, you have to measure the JPP. The normal, remember, the upper limit of the normal is 4 centimeter above the sternal angle, and add 5 centimeter to measure the central venous pressure, since the right atrium is 5 centimeter below the sternal angle. So when they ask you, see, you should not confuse the statement. What is the normal jugular venous pulsation? If they ask you, that is the height, it is less than 4 centimeter. Okay, less than or equal to 4 centimeter is the jugular venous pulse, vertical height in centimeter. But when they ask you pressure, you have to add 5 so that the answer will be in centimeter of water. So JVP, jugular venous pulse, is less than or equal to 4 centimeter, whereas jugular venous pressure is less than or equal to 9 centimeter of water. Remember, it is centimeter of water, not millimeter of mercury. So this is how things works. And what are the waves? You can see here, you can see A, C, V, and two negative waves, which are X and Y. So A, C, B are the three positive waves, and X and Y are the negative waves. Okay, fine. So let us first see how A waves. What is A wave? A wave is produced just before the first heart sound. Okay, and A wave is because of atrial contraction, right atrial contraction. A wave is because of right atrial contraction. Fine. Yes. And the C wave is because of the bulging of the tricuspid valve into the right atrium. Bulging of the tricuspid valve into the right atrium. Then X descent is because of the atrial relaxation. Atrial relaxation. V wave is because of the rising right atrial pressure when the blood flows into the right atrium during ventricular systole. Y descent is because of decline in the right atrial pressure when the tricuspid valve reopens. So once again, when they ask about A wave, it is because of the right atrial contraction. Then, okay, it is the venous distension due to right atrial contraction, and Then comes the C wave, which is because of the bulging of the tricuspid valve into the right atrium. Then comes X descent, which is because of the atrial relaxation. Then comes V wave because of the rising right atrial pressure during the ventricular systole, and Y descent is mainly because of the decline in right atrial pressure when the tricuspid valve reopens. So that's how A, C, then X, V, and Y happens. Fine. So what are the conditions you'll get low jugular venous pulse when the patient is in shock, hypovolemia? Elevated JVP occurs in case of left heart failure, valvular heart disease, cardiomyopathy, constrictive pericarditis, cardiac tamponade. Increased resistance to right ventricular filling is responsible for producing elevated A wave. It is elevated A wave which occurs in case of tricuspid and pulmonary stenosis. Characteristically in tricuspid stenosis, we can see a large A wave here. It is elevated A wave. Canon A wave is nothing else but not just elevated, the amplitude and width of the A wave increases. We call it as canon A wave, which is very characteristically seen in complete heart block or ventricular tachycardia. Remember these two conditions. Absent A wave is seen in atrial fibrillation. Elevated V wave. Why? Because V is because of the bulging of the tricuspid valve. So elevated V wave occurs in case of tricuspid regurgitation. Remember, elevated A wave occurs in case of tricuspid stenosis. Here, right ventricular failure or tricuspid regurgitation, we will get elevated V wave. And remember, there is another important thing, that is A wave. The amplitude of A wave is equal to V wave occurs in case of atrial septal defect. Okay, these things are extra. If you can remember, you remember. Otherwise, it is okay. And what are the other findings? I told you that elevated V wave occurs in case of tricuspid regurgitation. Tricuspid regurgitation, there is absent X descent and a very prominent Y descent. Absent X descent, prominent Y descent, along with elevated V wave are the three findings. Elevated V wave, absent X descent, and deep Y descent are the findings seen in case of tricuspid regurgitation. A wave amplitude equal to V wave amplitude in case of atrial septal defect. Remember, the X descent is prominent. Okay, prominent X descent occurs in case of constrictive pericarditis and cardiac tamponade, and as I told you, blunted or absent X descent occurs in case of tricuspid regurgitation. Prominent Y descent occurs in case of constrictive pericarditis, tricuspid regurgitation, and absent Y descent occurs in case of cardiac tamponade. Slow Y descent occurs in case of tricuspid stenosis. All these things are findings that you have to remember. That will be possible only after multiple revision. See, remember, in constrictive pericarditis, you will get the so-called prominent X and Y descent. Both X and Y descent is prominent in case of constrictive pericarditis. Okay, whereas in case of cardiac tamponade, there is a prominent X descent with an absent or blunted Y descent. Whereas prominent X descent and prominent Y descent is seen in case of constrictive pericarditis. So this is important. Okay, this is very commonly asked in your exam. Tamponade means X descent is prominent but Y descent is absent. X and Y both are prominent, constrictive pericarditis. And what is abdominal jugular reflex? It is positive. Okay, after you are just giving an abdominal pressure for some 10 seconds, and when the JVP increases, okay, above 3 to 4 centimeter of the normal value, we say that abdominal jugular reflex is positive, and it is a very characteristic bedside test to assess about right heart failure. And remember, the positive test occurs in case of tricuspid regurgitation. Again, it will precipitate right heart failure or classical right heart failure. Okay, yes. And what does positive test implies? That superior vena cava and IVC both are normal, and they are having very good blood flow, and they are taking the blood properly to the right atrium. So that is actually shown by abdominal jugular reflex. It is positive when the JVP increase after 10 seconds of abdominal pressure, followed by a rapid drop in pressure of 4 centimeters on release of compression. Or in simple words, when the JVP rises, okay, to more than 4 to 5 centimeter of the normal oscillating height of the blood column, we say that abdominal jugular reflex is positive. Positive means the patient is having right heart failure, SVC, IVC, patent. So, small sign, normally JVP decrease during inspiration. Failure of decline in JVP occurs during inspiration in case of constrictive pericarditis, Restrictive cardiomyopathy, tricuspid stenosis. Remember, Kussmaul sign is absent in tamponade. In cardiac tamponade, Kussmaul sign is absent. Thank you.